So I'm going to talk about this, the mouthful of late, which we'll call late, as opposed to the much longer broken down acronym. Really this is a recently defined disease that I think we all need to think a lot more about, because it has implications for our care of patients, and I'll go through some of the motivation around that. Here are my disclosures. And so just as a way of overview, I'm going to first try to provide some context about why late's important. I'm then going to talk about what are the sort of features of late clinically, the cognitive and imaging profile. And I think since a lot of people are clinicians here, I'm going to try to wrap that into a variety of cases that I'll show today of patients that have late. And just to foreshadow, when I think about late, I often think about late as a primary driver of symptoms in some individuals, as well as a really important co-pathology, specifically in Alzheimer's disease, but also with other conditions. And so I think of those sort of two contexts as a way to sort of break down how we tackle late. I will spend a little bit of time talking about some of the work we've done to try to disentangle when people with Alzheimer's disease do have late, given its importance. And then finally, at the end, I'll present our new diagnostic criteria for late that should come out in, I think, about a week from now. So I think it's worthwhile to kind of take a step back when we think about late and just realize that, we're in a new therapeutic era for Alzheimer's disease. I mean, this is just a monumental shift in what, how we take care of patients with Alzheimer's disease. And there are now 2 FDA-approved disease-modifying medications. And these figures just show how really remarkably well they remove amyloid from the brain. So the y-axis is a measure of amyloid PET. And with these drugs, essentially, in about 80% of these patients, after treatment with these drugs, they're amyloid negative. And I think if you just take a step back, the idea that, 1, we can even see Alzheimer's disease with a scan, 2, we can give a drug to affect the pathology of the disease, and 3, that it would have any kind of clinical impact is kind of amazing given how complicated this disease is and actually how brief the time window has been that we've really been dedicating research in this area. That being said, these are pretty modest benefits for patients. So it slows down the course of disease, but it does so modestly. So it slows it down maybe a quarter to a third, depending on which scale or measurement you use. So it has an impact, but it's not as great as we necessarily want it to be. And this is a spaghetti plot of outcomes in one of the trials with donanemab, and it shows just how people changed over time on 2 of the scales that we have. And it's it looks like hair to me. It's basically just a tangled web. And certainly people differ in where they start from, but they also greatly differ in their rate of decline. So I have a pointer. It's going to be hard to do, but there are people who have these kind of rapid rates of decline, and then there are people who are really flat. And I think the point is that Alzheimer's disease is an incredibly heterogeneous condition, and so it's hard to tell, even who's doing well with a drug versus not, because you don't have the counterfactual of how they would do without it. But it's again an extremely heterogeneous condition, and it's heterogeneous in a number of different ways. And I won't go through this whole list, but even the types of symptoms that you have, where the pathology is in the brain, when it starts, what are the kind of social and structural constructs that influence the disease, all those things have a really great impact on it. But one in particular that we've always been really interested in Penn is the presence of co-pathologies. And as I'll show you, Alzheimer's disease frequently is associated with more than just Alzheimer's disease. And in fact, this is data from our brain bank from a few years ago of people who had basically pathologically determined Alzheimer's disease. And what you can see is if you look for people who have plaques and tangles, which define Alzheimer's disease, only about a third of individuals only had plaques and tangles. Many of them had alpha-synuclein pathology, which is often associated with Lewy bodies and Parkinson's disease in people's mind. and then this other protein called TDP-43, which in this context is almost always late, and I'll define this a little bit more in the future. So 2/3 of Alzheimer's disease is not just Alzheimer's disease. And actually, if you throw in vascular disease, so this is from the Rush data set, the least common form of Alzheimer's disease is Alzheimer's disease. It's this little sliver. It's very atypical to just have Alzheimer's disease. And if you look at those with OD, which is not overdose, but other degenerative processes, again, TDP makes up a large proportion of individuals with Alzheimer's disease that also have that co-pathology. And so when we go back to thinking about, well, why do these drugs only have a modest benefit in individuals, I think there are probably a number of different reasons, but certainly one of them could be the influence of these co-pathologies. And so, we've actually thought a lot and tried to quantify and figure out ways, like how can we figure out partially how much of Alzheimer's disease is due to Alzheimer's disease in any individual. And it turns out it's really hard to do cross-sectionally. How do you quantitate it? Do you do it longitudinally? One way that the Rush group did this is a concept of attributable risk, where they took individuals who had clinical Alzheimer's disease and just calculated how much could it be attributed to Alzheimer's disease pathology. And it turns out less than about half of it can be attributed to Alzheimer's disease. And these other pathologies, particularly TDP-43, but also alpha-synuclein and vascular disease, contribute a significant percentage to the disease. And so, in reality, if you're only treating plaques and tangles, we don't know, but if you're only getting, amyloid plaques, there may be a ceiling to how much you can benefit a patient because of these other pathologies. So what is late? Cindy said it earlier. I'll say it again. It's a mouthful. Limbic predominant, age-related TDP-43 encephalopathy. Limbic because it involves the limbic structures of the brain, particularly hippocampus and amygdala. Age-related because it tends to be a later life neurodegenerative condition. TDP-43 because that's the primary protein that builds up in it, and encephalopathy because they needed an E. Okay? That is 100% true. All encephalopathy means, and actually it's been a source of great controversy to use this word, is a brain that's not working right. So there you have it. It really is a new entity in the sense that it wasn't defined as anything until 2019 when pathologic criteria for it came out. And just because you're going to see some terminology, people refer to late NC or late neuropathic change as meaning the pathology, and late as meaning the kind of clinical manifestation of the disease. What is TDP-43? It is a protein that is a ribonuclear protein that's involved in really maintenance and regulation of RNA, and its real function is to sit in the nucleus and regulate RNA and RNA splicing. But what happens in pathology is you have a loss of function, so the protein tends to leave the nucleus, and you get a gain of function in that it moves into the cell body and forms aggregates, just like amyloid plaques and tau tangles, and kind of clumps together. And it's really originally most known for its role in frontotemporal lobar degeneration as one of the main pathologies of FTD, as well as ALS. And actually the genetic forms of ALS, for the most part, with a couple exceptions, produce TDP-43 as the primary pathology. And then importantly, although maybe Henrik and Hartmouth will solve this, right now we don't have a molecular marker of TDP-43 that we can apply clinically. So you have to think of us as being back where Alzheimer's was 15 years ago, but where FTD still sort of is now. So that's just where we are. And it's not a totally new concept. So the idea that TDP-43 has a role in cognitive decline has actually there have been hints at it for a number of years. And the first was actually back in the 90s when Dennis Dixon at Mayo described these cases with something called hippocampal sclerosis, which is different from the the medial temporal sclerosis that we think of as being associated with epilepsy. This is a late life phenomenon, and probably the name is often a confusion to people. But he described in non-Alzheimer's disease cases, about 25% of their late life autopsies had hippocampal sclerosis. And I think he astutely described something that is part of the kind of clinical criteria for late now, which is that these individuals tended to have a really isolated amnestic syndrome out of proportion to other aspects of thinking. So memory was really affected in these patients, and yet they didn't have Alzheimer's, which was perplexing. And then the protein got discovered. I'm very proud that some of my colleagues, Virginia Lee and John Trojanowski, discovered this protein in 2006. Again, in relationship to ALS and FTLD, but then shortly after, it was found that those cases of hippocampal sclerosis, which is really injury, pretty severe injury to the medial temporal lobe, that they almost always had TDP-43 associated with them as well. And actually, this just shows you a picture from Dennis Dixon's initial paper of what hippocampal sclerosis looks like. So these are pyramidal cells in the hippocampus, and then you see them, they're nicely well formed, and then they just sort of go away, and there's just a loss of neurons there. And particularly in CA1 and the subiculum, which are important parts of the hippocampus. And so hippocampal sclerosis, in many ways, is the most extreme form of late, as we'll talk about. Really, it was in the teens that then a lot of groups, particularly led by a group at Mayo, Rush, and also Kentucky, started to describe that TDP-43, independent of Alzheimer's pathology, was associated with late life memory decline, as well as hippocampal atrophy. And then it started to become better known in these autopsy studies, and I'll show you a little bit more, that it was actually quite common in the absence of Alzheimer's disease, and that people over 80, about a third or even more, have some evidence of TDP-43 in their brain. Again, they don't look like frontotemporal lobar degeneration, they don't look like ALS, but they tend to have memory and hippocampal atrophy issues. And aptly, given our name, it was found that largely the TDP-43 was in limbic structures of the brain. And so this ultimately led to the definition of late, the pathologic definition in 2019, led by Pete Nelson, which basically described this protein and where it evolves or stages, or what its stages are in the brain. And what he described, and they try to simplify a kind of staging criteria, is that what you see in late, and this is distinct from other forms of TDP-43, that it begins in the amygdala, then moves to the hippocampus, and then moves out to more neocortical structures and middle frontal cortex. But one thing I think is helpful is there were some earlier staging schemes, one developed by Keith Josephs and one by Julie Schneider and her group. And I think if you look at where the other regions are that are involved, it gives you some clues as to what might be some symptoms associated with this, including insula and orbital frontal cortex. So one might expect maybe there's a little bit of behavioral symptoms in these patients. And in particular, anterior temporal polar cortex. And so one might think that there might be some aspects of semantic knowledge that are affected, because that part of the brain is really important in that, which is our kind of fact knowledge, word knowledge portion of the brain. Okay, so why should we care about detecting late clinically? Well, again, there's a growing awareness that TDP-43 plays a role in late life cognitive decline. And with the sort of reification of criteria, you start to think a lot more about this in our practice. Having criteria, having definitions really affects how we view the lens with which we view our patients and the world. And so because of that, we've started to diagnose or think about patients that maybe they have this condition. Clinicians have to clinish. And so once we get a diagnosis in mind, that's what we do. We clinish away. But I really think its importance has been really amplified by disease-modifying therapies, kind of in two ways. One is that this condition is a great mimic of Alzheimer's disease. And so the patients we're evaluating for anti-amyloid therapies are very frequently, when they're amyloid negative, going to have late. And so they're going to want to know, what do I have and what should I expect in the future? But then on the other side, even when we do diagnose Alzheimer's disease, it's going to be an important co-pathology in a significant proportion of these patients. And we don't know, do these people do as well when they're given anti-amyloid therapy? Maybe they do better, maybe it helps with both proteins, but we don't know, and we need to know that to better really reach this model of precision medicine where we're prescribing the best medicine and weighing the risks and benefits as best as possible for our patients. All right, so with that definition, we did start to think about patients that might have this, and so I'm going to give you a couple cases to start with. So the first is someone we saw in clinic who's a retired engineer, was in his early 80s and complained of forgetfulness. And what was really striking to his family is his grandson had made the high school hockey team, which was something that they had talked about for a really long time. And the next day he completely forgot that he had heard that he had made the team. And that was just really, really striking to the family. They noted he was keeping more notes for reminders. He was inefficient a little bit with the finances, but generally was able to do all of his normal activities of daily living, except for more memory-guided ones. And in his case, they didn't notice really any change in his personality or any kinds of language complaints. And he had a mini mental status examination at his first visit of 30 out of 30, and actually borderline memory performance, so it wasn't so bad. And this was his initial MRI scan, which for his age wasn't that abnormal, but there was some flattening of the anterior part of the hippocampus, which made us a little bit suspicious of a neurodegenerative process, and in fact, suspicious of Alzheimer's disease. And this is just his testing over time. He started off at 30 on his MMSE, but then kind of for a number of years, he went down, but then kind of went up again. And then really it wasn't until close to death, about 8 to 10 years after we diagnosed him, that he started to show more of a drop-off. But other domains were kind of largely intact. His language on tasks like fluency, like how many animals can you say in a minute, how many words can you say in a minute that begin with F, he did pretty well. Naming, Boston naming, very little change. Memory started off kind of modestly impaired, but then bottomed out, and that was the one aspect that just was very, very poor throughout our seeing him. And so we diagnosed him with Alzheimer's disease. And then, because he was participating in research, we got an amyloid PET scan. And of course, it was a negative amyloid PET scan, so this is no uptake of our amyloid tracer, and so he doesn't have Alzheimer's disease. And then this is what his MRI looked like at that point. And it was pretty impressive. One of the things that I noticed in a lot of these patients is there's a widening of a part of the brain called the collateral sulcus, which is where the entorhinal cortex and then this Brodmann's area 35, or what actually Brock called the transentorhinal cortex, there tends to be thinning and widening of that we see a lot in these patients. One of the hallmark features is the anterior part of the hippocampus, the head of the hippocampus can become quite atrophied and flat. And then really at this point, the whole body of the hippocampus was also quite small. So he has really, really tiny hippocampi in general. And so we actually, because these criteria came out, said, well, maybe he has late based on this. And he did, pathologically. And actually, this was the very first case we ever diagnosed with late at our center. And, we were 1 for 1. We hadn't stayed 1 for 1, but, or 100%. But we were 100% at that point because he had late stage 3, which means that it had gone even beyond the hippocampus in terms of where the pathology was. He had hippocampal sclerosis, so he had this more sort of severe form of late, which in many ways is helpful for our diagnosis, but he had very minimal Alzheimer's disease pathology. Just as another case to sort of show some of the spectrum of this, this was a 78-year-old woman with really minimal other medical issues. She had had uterine cancer but was cured of that and had a little bit of depression, but she also had memory loss, was misplacing things, forgetting where she parked her car. I mean, no one ever does that. Difficulty remembering events. And she had some more functional changes, a little more trouble using her computer, a little bit more stressed, and some struggles more with decisions. And then here's her testing profile. So in our center, we get a battery of standard psychometric tests and have normative data. And basically, this is 1 standard deviation below normal, and this is 1.5 standard deviation below normal, which we often consider truly an abnormal performance on a test. And I won't go through all this. This battery tests a number of different domains, but basically it was all the memory domains that were affected in her, to a large extent. Although she had kind of borderline animal fluency, which again is a kind of semantic task. Part of how you do well on that task is you kind of group together different kinds of animals, farm animals, then domestic animals, and zoo animals. So kind of borderline on that. And this was her initial MRI. Again, kind of flattening, more on the right than the left of the hippocampus. And you can kind of see an enlargement of the temporal horn, which often means the anterior part of the hippocampus is atrophic, and just a little bit of white matter disease. And here's her course, and I've had a number of patients like this that have just been remarkably stable over many, many years. So her mini-mental really didn't drop at all, maybe a point or two over 8 or 9 years. Her memory was poor to begin with and then just bottomed out also, just like that last person. But other domains were just kind of steady the entire time. So really just a pretty pure amnestic syndrome with a little bit of semantic memory loss, a little bit of decrease in motivation, so she had some degree of apathy, and she actually was a little bit disinhibited over time. Not like frontotemporal dementia disinhibited, but definitely disinhibited, was saying things that her family said she wouldn't normally say that. And so we diagnosed her with Alzheimer's disease. And this was 10 years after her initial scan. We didn't have biomarkers in her, but I hope you can appreciate it was a CT scan. We often see just almost this thread-like thinning of the cortex in, again, this area of the collateral sulcus, and now much more widening of the temporal pole and flattening of the hippocampus. And again, it's also atrophic posteriorly, but it tends to have this anterior to posterior gradient. And she too, when we went to autopsy, didn't have Alzheimer's disease. She had late. And I brought up this case in part because, one, we misdiagnosed her, and I now retrospectively go back and think about a lot of my patients that we probably said had Alzheimer's that really had late. And two, just to show that oftentimes this disease can be super, super indolent in people. And so, again, when we think about why do we want to diagnose it, because it actually has a prognostic implication for patients. So there's been a fair bit of work, mostly based on postmortem studies looking at antemortem data, that late produces a primarily amnestic syndrome. And so this was a study from Rush, and you probably can't see super well, but they looked at a number of different domains. And basically, while Alzheimer's disease gives you a classic amnestic multi-domain syndrome, this condition tends to be much more focused on memory. And generally, the course is slower than Alzheimer's disease. So if Alzheimer's disease moves at this rate, late tends to move at a much, much slower rate over time. A number of studies have suggested some degree of semantic involvement, and there's been some controversy about whether there's neurobehavioral symptoms associated with it. I think there is. I think it's not infrequent in these patients. It's often, though, very subtle, and so it's kind of within the spectrum of what you see with Alzheimer's, but I think it's more frequent in these patients. In another similar study looking across domains, here they looked at TDP-43 with or without hippocampal sclerosis. And again, I think, while this is a first approximation, I do think of hippocampal sclerosis as the more severe end of late, and these are the people who tend to have a little bit more aggressive late. And again, if you look across domains, Alzheimer's, this is cognitive performance before death. Alzheimer's is associated with a steady drop in memory, but also other domains are affected below this sort of zero line a number of years before death, whereas TDP alone without hippocampal sclerosis really has a pretty isolated memory loss. And with hippocampal sclerosis, it's more severe, but again, these patients also tend to have more of spread into these cortical areas, and they also tend to have more semantic deficits as well. What do you see in the brain when you look at these structurally? We've looked a little bit at some hippocampi. This is a post-mortem imaging study out of Rush, where what you see is actually atrophy that's greatest in the sort of areas that were staged with TDP-43, meaning that where there's TDP-43 is where there's atrophy in the brain. And the sort of more yellow colors are the most severe areas, and it really tends to be medial temporal and temporal polar interorbital frontal cortex that are the most severe areas affected. And then this is a study of antemortem imaging, so scans that were done during life in people who went on to have late at autopsy. And again, you really can kind of appreciate this anterior temporal polar, medial temporal atrophy pattern that you see in these patients. As an aside, for those of you who are not so deeply in the FTD world, TDP-43 is often broken down into these different pathologic subtypes based on what the aggregates look like in the brain. And there are actually at least 5 of these subtypes, but the 3 main ones are something called type A, type B, and distinctive pattern of type C, which are these long neurites which have TDP-43 in them. It turns out that pathologically, TDP or late looks like type A, which again, if you know a little bit about FTD, is associated with granulin mutations. However, it's really type C that the anatomy overlaps with. And so this is work by Marcel Messelam, who at Northwestern, who showed the pattern of type C cases. And what does type C give you? It often gives you what's called semantic dementia or semantic variant PPA, primary progressive aphasia. And the bottom line is what is seen here is earliest there's temporal polar atrophy that moves into more inferior areas, but includes Brodmann's area 35 and 36, which is what I was talking about earlier in the collateral sulcus, and then moves to amygdala and hippocampus later. So kind of an opposite pattern of where the spread is, but very much overlapping. And I think it's just something I've noted in these clinically defined late cases, that there's just really a tremendous amount of overlap in atrophy patterns with temporal polar areas, amygdala, and again into kind of in medial inferior temporal regions in our late cases. And so there is some degree of overlap with these conditions within this kind of network of connected areas. So late causes hippocampal atrophy, as we've talked about. And I think interestingly and importantly, if you look at cases with AD versus cases with late, and again, this is post-mortem imaging, late, if anything, is associated with more severe hippocampal atrophy than typically what we see in Alzheimer's disease. And I just put this in here because many of you are clinicians, that there are visual clues to how atrophic the medial temporal lobe is. And generally, this is something called the Shelton scale. Individuals with late, at least more severe late, kind of look like stage 4 or stage 3 of Shelton scans. So you can kind of burn that image into your head a little bit as something to kind of look for in these cases. We've also seen that there's not just the hippocampus is affected, but that there's a pattern to how it's affected using more advanced kinds of imaging tools. And so this was a study that my postdoc a couple of years ago did, where we looked at really detailed anatomy of the medial temporal lobe with imaging. This is a kind of rendition of the medial temporal lobe, which includes the hippocampus, but also these extra hippocampal structures. And basically what we saw in individuals that we had autopsy data on, but imaging in life, was that with TDP-43, there was generally greater atrophy in more anterior parts of the medial temporal lobe. And actually, if you took a ratio of regions in the anterior part of the medial temporal lobe to posterior, we could differentiate with pretty good accuracy, 80% accuracy, those with AD with late versus those with AD or without TDP, I should say. There's also been some PET imaging that has been suggestive of patterns that you see with late, and in general, it kind of overlaps with the areas that you might expect. It tends to be more temporal polar and definitely involving medial temporal lobe and orbital frontal areas, but less inferior temporal and lateral temporal and parietal than Alzheimer's disease is. And David Jones and others at Mayo have developed a ratio of that, which gives you also sort of somewhat similar accuracy to what we saw with hippocampal sort of measurements or medial temporal measurements. And so potentially useful tool, and there's some argument that radiologists can read this, but I think it requires a bit of training. Okay, so we've talked a lot about late kind of mostly alone, but really I think where late has also a very, very big impact is that it co-occurs with Alzheimer's disease quite frequently. And in fact, by the time people reach late stages of Alzheimer's disease, more than half of them will have late in the brain. And so this is work based on a community and population-based autopsy cohorts, sort of aggregating over 6,000 brains, which is kind of amazing. And basically, in each of these figures, these are varying levels of AD severity, and in blue are the proportion of people with late NC. And so, with very little Alzheimer's disease, in fact, really no Alzheimer's disease, about 20% of this population at late, which is, kind of akin to what we were talking about earlier. But as Alzheimer's disease progresses, a greater proportion of individuals have late, and again, up to about 50% of those individuals. And then I showed you what late looks like relative to AD, but when you have late and AD, there's lots of data that these people are actually some of your fastest progressors with Alzheimer's disease. So it seems to accelerate the course of Alzheimer's disease. And we even see that with imaging. So this is looking at hippocampal atrophy in people with AD alone versus AD plus late. And so there's a faster rate of decline in individuals with mixed pathology. This just shows these are the relative risk of having moderate to high Alzheimer's disease relative to low to no Alzheimer's disease in different decades. This is work Pete Nelson did, where it does increase with age, but it also increases again with having Alzheimer's disease. But one other place that you see a relationship of late is with arteriosclerosis. And so it does seem like, particularly later in life, that vascular disease also seems to increase your risk of having late as well. And so it's a little unclear what that relationship is. I also put this in because I think it's important for us to think about, which is that this is data from our postmortem data set where we're doing much more quantitative measures of tau and TDP-43. And basically, even if you match patients with Alzheimer's disease at stage, people with TDP-43 tend to have higher levels of tau pathology also in the medial temporal lobes. And so there's just a greater density of tau pathology, which we all know is associated with the atrophy of Alzheimer's disease. And there does seem to be a synergy between TDP-43 and tau pathology. And there's even mouse model data showing that in models of TDP-43 that if you have tau pathology, there's greater spread and load of tau. And so there's some sort of relationship there between these pathologies. So I showed this earlier, which shows when we compare Alzheimer's disease to late in terms of hippocampal volume. One other thing I like to point out, because they, in this analysis, broke down people also who had AD plus late, is not surprisingly, when you have AD and late, you have also more severe atrophy than AD alone. But if you kind of basically pick the bottom quartile range of patients with Alzheimer's disease, the sort of spectrum of what we see, it's really enriched in people with late, and so that can actually be a clue, a diagnostic clue that you have AD plus late, in that really what we used to think of as the range of typical Alzheimer's disease, the bottom part of that range is probably not Alzheimer's disease. A lot of that's going to be driven by late, and that is a helpful clinical clue for us. All right, so how do we start to deal with late when it's in combination with Alzheimer's disease? And so this is another case, and so this is a woman in her 70s who had primarily memory complaints, was forgetting appointments, conversations, had less orientation to time. Here's our testing again. She did okay on one set of memory tests, but poorly on two others. So this is a delayed recall word list test, and this is a story test where she was quite impaired. And then she showed also some impairment, but borderline on a visual memory test. And then a little bit of issues with executive function and planning, so she didn't do the best clock in the world. And then we got spinal fluid in her, and actually she had low A beta, so consistent with Alzheimer's disease, but interestingly she had pretty normal tau and phospho-tau, and so really just showed signal with amyloid, at least with this measure. And her diagnosis was mild cognitive impairment due to Alzheimer's disease because of her spinal fluid. And this is her initial MRI, and I hope you're getting the theme here. She also had a pattern that we've discussed already that's pretty typical of late, very severe atrophy. She had some degree of white matter hyperintensities, and here you can really see her atrophy in the medial temporal lobe and the temporal pole the temporal horn of the lateral ventricle being much more enlarged. And we actually quantitate hippocampal volumes at our center, and these two red dotted lines are the middle 75 or 50% of mild Alzheimer's disease in terms of atrophy, and she's well below that line. So she's a really severe atrophy for Alzheimer's, and really severe atrophy at this mild cognitive impairment stage of Alzheimer's disease. And so we followed her for 15 years. She had a really slow course. When she died, she actually did have Alzheimer's disease. She had intermediate Alzheimer's disease, BROC, using the ABC score BROC2, but what we think of as BROC3-4, which kind of is a little bit odd, right? If she had Alzheimer's the whole time, why wasn't she more severe 15 years later? She had late stage 3 though, so that was in combination, and she also had amyloid angiopathy as well. And so this patient would have qualified for anti-amyloid therapy. Question is, was Alzheimer's causing her symptoms when we first saw her? I don't know. I mean, I can't say for sure, but I would have expected more tangle pathology at this point, or at that early stage, than we likely saw. And I think it's worth keeping in mind that if you look at data sets like the ADNI initiative, about 25% of mild cognitive impairment patients don't have evidence of tau, at least measured by tau PET. Now you can argue about the sensitivity of tau PET, but generally when tau is causing symptoms, tau PET signal is up enough that you actually see it. And in fact, we did a study where we looked at patients and then found that a third of mild cognitive patients had amyloid that was positive, that had evidence of neurodegeneration but didn't have evidence of tau pathology. And this is what they look like in terms of their atrophy pattern. They kind of look like cases of late, which is this more anterior kind of temporal polar atrophy. All right, and then this is a case where it's even more complicated. This is someone who has potentially has late as a co-pathology. It's a man in his 70s with, again, forgetfulness. Mini-mental of 26, so still very, very mild. He did really poorly on his memory tests, also actually didn't do so great on the clock, but other domains largely intact. And then this is his spinal fluid. And so he had both low A beta and elevated phospho-tau. So he has Alzheimer's disease, for sure. And then this is his MRI. And again, I don't know, seeing some of the same kinds of things here. So I don't know, what does that mean in this case? And then this is where he was in terms of hippocampal volume. He was in the bottom quartile of hippocampal volume for his age. Not quite as bad as that last patient, but still very much at the low end for mild Alzheimer's disease, even though he was really in the kind of MCI range. And then this was his pathology. So he had Alzheimer's disease, full-blown high-level Alzheimer's disease, but also had late. And so were both of these conditions present and causing symptoms? I don't know for sure, but I kind of suspect that might be the case. And so we started to try to come up with a way to, how can we start to think about who has Alzheimer's disease, but how much is Alzheimer's disease contributing versus these other factors? And so we tried to use initially the now older framework of the ATN model for classifying patients, where one can get information about amyloid and tau, which define Alzheimer's disease. But one can also measure some sort of downstream marker of neurodegeneration, which we think of as the atrophy we see on an MRI scan or hypometabolism that we see on PET. Neurodegeneration has these parentheses, it's like its scarlet letter, this Hester Prynne of the biomarker world, where it is non-specific for Alzheimer's disease. And so we thought, well, okay, it is non-specific, and it probably is non-specific because, yes, you see atrophy due to Alzheimer's disease, but brain structure is affected by other pathologies, by vascular disease. Just normal aging is associated with some degree of brain structural loss without a sort of pathology that a pathologist would view under a microscope. And also there's just individual differences in all of us. We all have different brain sizes and shapes, and all those things influence our measure of neurodegeneration, particularly when we do it cross-sectionally, which is often how we study it. And so we wondered, well, could we kind of leverage that non-specificity to get clues about other co-pathologies when we don't have a good marker of them, such as for TDP43, and maybe the pattern and severity of that can help us get an idea of the degree to which these other pathologies are affecting things. And so we wanted to think, well, can we in any way measure how much atrophy should the brain have due to Alzheimer's disease? Can we kind of parcelate out the part of the atrophy that is due to Alzheimer's disease? And it turns out, to a first approximation, that tau PET is a very good marker of where there should be neurodegeneration in the brain. As many of you know, amyloid may be a more antecedent event in Alzheimer's disease, but tau is what's really linked to the injury in the brain. And we now have tau PET. And I think this paper really nicely illustrates that tau PET really overlaps with where there's atrophy. So this is from Bill Jagis's group, and on the left is just a pattern of tau uptake. Hotter areas are redder, or higher levels of tau. And if you look at longitudinal atrophy, it just completely overlaps with what you see with where there is tau pathology in the brain. And so we thought, well, maybe tau distribution and severity is kind of an answer sheet for how much atrophy we would expect to see due to Alzheimer's disease. And so maybe we could kind of use that information. And so what we tried to do in different, sort of across the whole brain is, can we come up with a normative relationship between tau pathology and atrophy? And so here is one region of the brain. This is inferior temporal gyrus on the right. And the y-axis is cortical thinning. So the lower down it is, the worse off you are. And the x-axis is tau PET uptake. And basically we see an expected relationship, that the more tau there is, the more atrophy there is. But it's worth pointing out that there are people who have less atrophy than you'd expect for tau, and perhaps they're more resilient. But you also have people who have a lot more atrophy than you'd expect for a given level of tau. And we could call them vulnerable, but maybe many of them have that because they harbor co-pathologies. And so we actually started looking at this in individual brains, and we sort of thresholded what's a level of too much atrophy, how many standard deviations away from the mean should you be to classify a region as having too much atrophy. And so in red, these are people thresholded at about 1.5 standard deviations below the mean. And we started seeing these patterns where we saw some people who had kind of areas that were too vulnerable in anterior temporal regions, and then we found people who had more diffuse levels of atrophy, and we performed a clustering, spatial clustering analysis on that, and in fact we did find groups of brains that once we residualized out the effect of tau, we saw patterns of where there was either too much atrophy, and in some cases too little atrophy, or people who were more resilient. We of course had the Goldilocks group, which had the right amount of atrophy for tau, but we found a little bit vulnerable group that was very interesting to us, where there was more atrophy. So you kind of think of this as like we've regressed out Alzheimer's, and now we're just looking at what's left in the brain. We also found resilient groups, and including resilient groups that actually kind of had the opposite pattern in the brain. Some of this is statistics, but I have sort of an idea about those groups as well. I think importantly, when you look at this, and even when you covary for tau to kind of control for disease severity, these vulnerable groups have much faster rates of decline cognitively over time compared to our canonical group in black. And actually the resilient people didn't change very much at all. But I think this is important because these are clinically people that, again, if they do harbor some sort of co-pathology, are showing this more rapid rate of decline. Well, when we regress things out of the brain and we're looking at what's left, we should kind of see that same pattern then in people who are symptomatic, who are amyloid negative, who don't have Alzheimer's disease, if we just look at their patterns of atrophy. And in fact, that's exactly what we saw. So we saw a amyloid negative group that also had this sort of temporal pattern. And they look really, really, really similar to each other. And I think they look a lot like that postmortem imaging that we showed before of what the pattern is for late. So we were thinking maybe this group reflects late. And so to test this a bit more, we did an analysis where we looked at antemortem imaging in people that we had autopsy data for, and we kind of residualized out the effect of a measure of tau load in the brain
and looked at structure. And again, we found this limbic predominant group. We also found a resilient group in almost the same set of regions. And interestingly, the limbic predominant group had higher levels of TDP-43 than our canonical group. And actually this other group, the resilient group, had less levels of TDP-43. And I think some of the resilience we see, since AD is so common to have co-pathology, or people who particularly have no co-pathology, who are resistant to co-pathology, and that may be at least one source of resilience. I'm not going to get into this in too much detail, but we have tried to work further to validate this kind of approach using postmortem imaging. So every autopsy that we get at Penn, we get a hemisphere that we scan postmortemly in our 7T scanner. And then we also do dense histology on that. And basically, we've been able to group patients who have Alzheimer's disease with and without late, both with antemortem imaging as well as just with postmortem imaging. And actually, I work with some really brilliant colleagues who've developed methods for registering histology, quantitative histology to postmortem imaging, and then to bringing this into a three-dimensional space where we can really look at the structures in very fine detail in the medial temporal lobe. But basically what you can do with this sample is you don't have to, we can actually know the normative relationship between tau and structure because you can just look at cases that only have tau in it. And we can form a regression line. And then we can look at cases that also have concomitant TDP-43. And as we would have expected, they all fall off, or many of them fall off that regression line. And so we can measure residuals, and when we do that, we see lower residuals, meaning more atrophy than expected for tau, in our late plus AD group, in the CA1 area of the hippocampus, which is where we tend to see TDP-43, in the entorhinal cortex, which is another area where TDP-43 is in high levels, but not in posterior regions. We don't see the same kind of dissociation. And I'll just say we've done the same thing with antemortem imaging, that we have postmortem scans where, again, in hippocampus we see, particularly anterior hippocampus, lower residuals, again, suggesting greater atrophy than expected, but in posterior areas we don't see that effect. So it seems like the mismatch concept makes some sense, at least, and does so even with more quantitative data. So based on all of what I've said in the last 2 or 3 minutes, I'm just going to provide you now with a framework that we've developed based on these data to really diagnose late in clinical practice. And so this started out, actually, it was a lot of work. It started out with a committee that met of 36 experts, where we had this NIH-funded or sponsored Gaps and Opportunities session where we just talked about where we were as a field clinically with this, and emergent from that meeting was a great interest in trying to develop clinical criteria. And so we developed kind of a framework for that, and then moved on subsequent to that meeting to iterate on that. We knew that in the absence of a marker for TDP-43, that our diagnosis was going to be probabilistic, but we've been doing that for years. Our field is, often talked about probable and possible Alzheimer's disease, so we know how to do that. And that we would define it in 2 clinical contexts. One, when late seems to be the primary driver of symptoms, and for that we can call it possible or probable late. And then 2, when it's mixed with Alzheimer's disease. And for those, I think we all felt that we're only at a stage where we can have some confidence, not really high confidence of the diagnosis, so we'd only call that possible late. We described 2 kind of core clinical syndromes for those 2 conditions. One is a core clinical syndrome where late's the primary driver, where many of the features we've already talked about are present. So an amnestic syndrome that's primarily out of proportion to other domains, although there can be a little bit of semantic memory that we see, tends to occur late in life, tends to be relatively indolent. So, you want to have some history of a couple-year decline by the time people see you. And then our core kind of clinical syndrome for mixed is a little bit harder because you're going to have the amnestic multi-domain syndrome of Alzheimer's disease, but you may have disproportionate memory impairment than what you'd expect, and you're typically going to have a more rapid course, but it's admittedly a relatively vague syndrome. And so then one can kind of create this algorithm where if someone has the core clinical criteria for late as a primary driver, you then need to have hippocampal atrophy. We need to have some objective evidence of atrophy showing downstream effects of late to feel confident in the diagnosis. You can use we gave recommendations around the Shelton scale I talked about earlier to make it more clinically practical. If you don't have biomarkers, though, really the best you can say is possible late, because it's just too hard to distinguish this condition from Alzheimer's. But Alzheimer's biomarkers are really helpful in these patients. And so if you have an amyloid biomarker and you're negative, well then you probably have late, because if you have this syndrome and that degree of hippocampal atrophy, there are not that many other things that would likely cause that. If you're amyloid positive, well, you still could have late, but you need some sort of tau biomarker. And right now, really, and this makes it less clinically practical, tau PET is really probably the only tau biomarker I would feel particularly confident about in this regard. But if you were tau negative, we could at least say you have possible late. There's a bit of debate about this in terms of sensitivity of tau PET. I would favor probable late in these cases, but others felt like perhaps tau PET's sensitivity is not good enough to know when someone might have enough tau pathology to cause hippocampal atrophy. But if you are tau positive, you have Alzheimer's disease, right? You're amyloid and tau positive. The question is, you could still have mixed AD and late. And so in these cases, you have that core clinical criteria, and then we really rely on some degree of clinical judgment and the severity of hippocampal atrophy being more severe than we typically expect in very mild cases or mild cognitive impairment, maybe this degree of mismatch. Also, FDG PET seems to produce more of a mixed pattern in these cases, and so that can also potentially be helpful. But again, at the best, we can call them possible late. That being said, I think we can enrich cohorts in this form of possible late and also this form of possible late for patients who are getting treated with therapies to begin to stratify them and better understand what happens to these patients, even in the absence of biomarkers. So just to conclude, late is common and important driver of late life cognitive impairment. It's a common co-pathology of Alzheimer's disease. There are imaging features and cognitive features that are suggestive of it. And I think we can get a probabilistic designation. The clinical criteria require validation. I already know one group that's been working on this in Sweden. I think some of us here can guess who that is. That has shown some pretty nice data actually supporting these criteria. But it needs to be validated in vivo studies. So just want to thank my colleagues. This is a lot of work with a lot of different people, and also thank the co-authors for our criteria. A number of us worked quite hard on that as well. And then I want to thank you all for your attention.